Hello, my name's David Hogan, and I'd like to welcome everyone to this event. So good evening, everyone. And this is a virtual public event titled Thinking Small for Facility-Based Continuing Care in Alberta. I would first want to start with our land acknowledgement. I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in Southern Alberta. And the city of Calgary is also home to Métis Nation of Alberta, Region 3. As a Center of Aging, I would like to, in addition, acknowledge the very valued roles older Indigenous persons fill in their communities, including as grandparents, elders, and knowledge keepers. COVID-19 heightened awareness of shortcomings of current ways of delivering facility-based care to older adults in our country. Small home models of care delivery have caught the public's imagination for many reasons. Alberta has been home to a few of them in the past, and I believe you will hear briefly about some of them. But none of these earlier initiatives have been adopted on a wider scale. The Alberta Facility-Based Continuing Care Review, prepared by MNP for the provincial government, and I should mention there's a link to that and link to other valuable resources on our event page. In that report, there was a recommendation that the government should set a target to develop approximately 1,600 small home facility-based continuing care spaces in our province by 2030. There is another recommendation noting that there is a need to examine how they will be funded. A draft Canadian Agency for Drugs and Technologies in Health review on small home models to support older adults in long-term care noted a number of different models with differences, which may or may not be important, but also three recurring themes: functional units with a small group of residents, encouragement of their participation in, for example, familiar domestic routines, and third, decentralized staffing with different roles and skill sets than what is currently the norm. The review also underscored the need for more evidence and also noted how heterogeneous the limited evidence that we have truly is. In their environmental scan, they included 70 publications. The most cited, with 24, was a greenhouse project model that you'll soon hear more about. I also want to mention that small house models, in whole or in part, might be appropriate for older adults with lower care needs than what you see in long-term care or other potential groupings of residents. We're pleased to introduce our audience members to one particular small home model that has history, 17 plus years, spread, 300 plus facilities, and a building evidence base of effectiveness, the Greenhouse Project. We're not stating this is the only model that should be considered, or that we should not forget our need to support aging in place, but feel we can learn much by examining this particular approach and its components, followed by thinking about how it might fit within our province and its health and housing sector. This is not a standalone event that will produce all the answers. Our hope is that it will inform the discussions that will follow our gathering tonight on the Bow. Let me give you a brief outline of the evening. Our keynote speakers will introduce you to the Greenhouse Project and will share the state of evidence on this style of care delivery. Following the keynotes, you will hear from panelists who will share their perspectives on how the small house model might fit into Alberta's future. Then both our speakers and panelists will answer as many questions from the audience as we have time for, including some that were submitted beforehand. And when you do submit questions during the event, please do it through the Q&A function. At the end, you'll hear about a local project being led by Dementia Network Calgary and about opportunities for further involvement. Now, I'm delighted to welcome both Susan Ryan, Senior Director of the Greenhouse Project, and Dr. Cheryl Zimmerman, a professor and academic researcher from University of North Carolina at Chapel Hill, who has been studying greenhouse facilities. Susan, who will speak first, has been a member of the Greenhouse team since 2008. She has become an internationally recognized leader in long-term care reform with a particular focus on the vision for small home elder care communities that provide person-directed alternatives to traditional nursing homes. Susan's co-presenter, Cheryl, is internationally recognized as an expert in long-term care services and supports for older adults, especially related to residential care and new models of care. She has led numerous research projects funded by the National Institutes of Health in the US, the Alzheimer's Association, and others, including the evaluation of the greenhouse model of nursing home care. Susan, you may share your slides and begin.
Well, thank you so much for your kind words, and thank you so much for the opportunity to be with you. I really, truly am delighted to be with everyone today. And David, I thought you gave a wonderful setup for what we're about to talk about. And it's really about learning and growing from each other. I think that there's not one group that has all the answers. COVID has certainly exposed the flaws and the weaknesses in all of our systems. And I think we're all trying to wrap our heads around really, truly, what is that model for us? My background is nursing. I have spent a 40-year career in nursing. There was a moment as a director of nursing where I said, long-term care, our best practices are not good enough. And I did everything I could to keep people in home care. And after a time, I realized we didn't have the infrastructure built in home care. It was cost prohibitive and socially isolating. And so I went back into long-term care to really seek reform. In 2005, I heard about the Greenhouse Project. It was where my world's home care and long-term care came together in a beautiful way. And in 2008, I joined the team. And it was in 2020 that the words you see on the left-hand side of your screen were really the words that were something that I said as COVID was just entering the United States with a roar. And somebody asked me, I was on a panel, and they said, so tell me, how will the greenhouse model do during the pandemic? And I made a rather audacious claim. I said, I believe the greenhouse model was made for this moment. I believe it's the best infection control mitigation measure, and I think we're going to be just fine. And then I got really worried as COVID started ripping and roaring through nursing homes across the states. So let's talk a little bit about what the greenhouse model is. What you see on your screen is a greenhouse home. It is licensed as skilled nursing, and it is in Colorado. And so you see a beautiful home for 12 people. But let's unpack it, lest you think it's all about the physical environment. I can tell you as a nurse that the greenhouse model is really a radical transformation of the institutional paradigm. For years as a nurse, goodness sakes, I was steeped in the institutional paradigm. When I heard about greenhouse, it really radically disrupted everything I knew about the paradigm in which I had done long-term care. And it wasn't just the physical environment that had changed with greenhouse. Greenhouse is comprehensively changing, not just the physical environment, but it's really thinking about what is that philosophical culture. So many times I have architects that have built beautiful small houses, but until we've really thought about the philosophical culture that goes into those homes, we've only done a third of what's really there. And last but not least, it's the organizational structure. And it's really thinking about it from a workforce perspective. And what must we do from an organizational design to really ensure that we've got that radical change that's really going to matter and really make a difference. And finally, it is sustainable change. I did a lot of work in what we would call broadly culture change, and it was all about implementing well. And so we focus so hard on making sure we implement it well. The greenhouse model is about not just implementing, but what will we do and how will we think about change from the very beginning in terms of the process of sustaining change, because how incredibly important is that as well. So the greenhouse model starts when we're thinking about what it is. we start with this fundamental question. And the question is, what would you need? If you were moving into long-term care tomorrow, what would you need to live life on your own terms? And this is a really important question. And when I think about what this question means, what it's getting at, it really is getting at our needs, their needs, our needs as humans. It's a shared humanity perspective. When I think about ageism and its root and the stigmas and the stereotypes associated with people as they are growing older, when I think about the devaluation and the marginalization and what do they need and the otherism that can occur, this question is really paramount to thinking about what would I need? What would you need? And how does that change or differ from older adults? And so really framing it in this context is really getting at ageism and recognizing we are humans first and foremost. And it's really starting with that question, what would I need? What would you need to be able to live life on our own terms, to be able to have dignified, humane approaches to the way we receive care in long-term care? So let's start with that first core value, the physical environment and everything that we see. And everything that we see, we want real home. I don't want home-like, I want a real home. And real home would look different depending on where we are and the type of community in which we find ourselves. So here are greenhouse homes around the country. And in the top left, you will see John Knox Village. They're in Pompano Beach, Florida. There are 12 greenhouse homes. As you can see, it's a vertical model. And so they've got 2 greenhouse homes, one on either side of the elevator bank that's in the middle. So it's a 7-story building, 12 greenhouse homes, 2 on each floor from 2 through 7. And so that's home in their community. It's a bit more urban environment. And so they have gone vertically. They didn't have a large spot of land. And so that's how they did that home. Going clockwise, you will see a beautiful home in Loveland, Colorado, single family home. They have 9 single family homes in that community. In this case, it's 10 elders in that home. And last but not least, we have a 3-story building, a greenhouse home on each story there. And in that home in Birmingham, Alabama, it's more of a suburban type. They've got 9 greenhouse homes, 3 buildings with 3 greenhouse homes in each of those buildings. And with each of these are greenhouse homes that fit within the surrounding community. So really, let's think about what makes a real home versus home-like. I don't know about you, but I'm not so interested in living in a home-like environment. I want a real home. And so what is a real home? Smaller is better. And that's the whole premise of why we're here tonight, is to really think small. And how do we really just pare it down to create small homes of 10 or no more than 12 people per home, autonomously functioning households? And what about private rooms and private baths? And think about this through the lens of COVID and how important it was to have a private room with your own private bath. And then opening, we think, social connectedness and the humanness of our need to connect. There's a hearth area, and at the top of your screen, you will see the beautiful hearth area at John Knox Village, where you've got a fireplace on one side and the open kitchen, the food on the other side. Access to outside, and I'll say more about that in a moment. And in the very bottom of the slide, you'll see an open kitchen where elders are able to kind of come up to the bar that's there, talk to the caregiver who's preparing the meal. That's home. That's real home. In addition to that, can I mention how important access is to outside? As a nurse, and I think about COVID, and I think about how important it was to get outside from a mobility perspective, to just move and to get outside, from a fresh air, ventilation, vitamin D, that exposure to the sunshine, how important it was to move and to get outside. I know it was important to me and for our elders as well in greenhouse homes, how important it was for them as well. So if you're in a vertical building, we believe that's still important. So off each greenhouse home in that vertical building, there are screened in porches. So elders are able to get out on the screened porch and be able to feel the fresh air, to be able to connect with nature in a meaningful way. What you don't see in this picture are the beautiful pots where they do a lot of gardening. So they've got the opportunity to get their hands dirty. And obviously on the main floor, you'd be able to get outside and into a courtyard for them to have that exposure. So here are some pictures that I'm going to talk about our next core value in the context of a philosophical culture. And that philosophical culture really translates to meaningful life. It's not just about person-centered care, but how do we ensure people are able to live a meaningful life, to live a life that's meaningful and purposeful. This is a couple you see here in this picture that they happen to have been celebrating an anniversary. And so it was important, the care team determined that they should have dinner on the patio. And so this is the courtyard of their greenhouse home, and they were able to serve them dinner, and this is their cake and a little bubbly on the side for them to celebrate their incredible anniversary. So meaningful life, it really happens in the context of deep knowing relationships. You need to know who the people are that are living in the home. It's not them, but who are the individuals and what's important to each of those individuals so they're able to live life. They're able to have some autonomy and control and how they really direct the way they live their lives. It's, as I said, it's purposeful engagements. It's not just fold the towels and I'll unfold them and then you fold them again, but what's meaningful, what's purposeful to each person. You see somebody that is actually an elder. She's there cooking in the kitchen because that's meaningful to her. In the very center, you will see a gentleman who's living in a greenhouse home who happened to have been a farmer. And the care partner realized that it was important to him to get outside and watch the fields that were being plowed. He was a farmer previously in Arkansas. How do we honor the natural rhythms of a person? So it's not everybody gets up and does the same thing each day, but how do we know people as individuals and what's important to that person and what's that person's rhythm? Are they going to get up at 6 and want that cup of coffee and a full breakfast? Or are they going to sleep till 10 or 11 and just want a cup of coffee? And last but not least, it's that social connectedness. And I don't know about you, but I realized how incredibly important it was to me to have that social connectedness. How it's no different for people that are in long-term care communities. And we just believe that social isolation took its toll on the people that are living in traditional nursing homes and how important it was to really strive to keep people connected. I wanted to talk briefly about our memory care approach. We call it the Best Life Memory Care Approach. It builds upon the greenhouse core values that I've talked about. I've talked about 2 of the 3. I'll talk about our empowered workforce in just a minute. But I thought it was important that you understand about dementia and how does dementia and those with cognitive impairment, how are they really supported in a greenhouse community? We have developed a memory care approach, as I mentioned, it's Best Life approach. These are the 4 principles that we build upon. The power of normal, it really is all about having elders live in the least restrictive environment possible. We want them to experience the culturally typical activities. They should have access to some of the same things you or I would have access to. We want them to be age appropriate. We normalize our programs, we normalize our environments. The power of normal to really speak into people. Focus on retained abilities. How often is it when we think about somebody with cognitive impairment, we think about what they've lost instead of what's left and what are those retained abilities and how if we focus there, what might we do to be able to support those retained abilities to help them live their best life? Going to the other left, bottom left, dignity of risk. And I think how we learned in COVID, our propensity to lock people up to keep them safe, the surplus safety. It is our institutional default. As a nurse, I can tell you that's how I was schooled. That's what I thought, keep them safe at all costs. But recognizing there is a dignity in risk taking. As humans, it's part of our human rights to be able to engage in that. Not that we let everybody engage full steam, but to really recognize that it is a human right. And what can we do and how can we honor the fact there is dignity in risk taking and really rethink what that means. And last but not least, it's a focus on advocacy and really making sure we're equipping our teams to be able to advocate for those people that are in the greenhouse homes living with cognitive impairment. I'm not going to spend any time here, but this is the process. We kind of work in phases to kind of assess where you are, to create that vision, to equip the teams with everything they need to be successful, and then to really develop the sustainability plan, develop the metrics. How will we know we're successful? By the metrics in which we will hold ourselves accountable. So that's just a real quick bit about how we would work with an organization to do the best life approach. So our last, but certainly not least, and when we think about workforce and the staffing crisis, that it's not just in the US, but I'm sure that Canada is dealing with it as well. Empowered staff is that organizational redesign and really thinking about how do we flatten the hierarchy to be able to give voice to those working closest to the elders about sharing power with wise leaders. And so the greenhouse model works with universal workers. And so we really take that care partner who is equipped to provide the care and bring education to them so they're able to do the cooking, the cleaning, the laundry. And so you have more of the direct care time who are working in consistent teams, and they are working in partnership and collaboration with the clinical support team and other members to be able to share in decision-making and problem solving. When there's a problem that comes up, it's not a top-down approach to solving it, but let's solve it together. And let's talk to the people who are working on the front lines to make it happen. It's all about a coaching culture. The universal worker, it really is creating a level of ownership that you just don't really see typically in traditional settings. So you can see here the confidence that's exuded as they are going through here. Empowered staff, it's all about leadership. I can't say enough about what that means there. Moving forward, just to talk a little bit about the difference in cost shifting. How do you make this work? It really is about doing the cost shifting. If it's a universal worker, it's less dietary time, and you're going to have more CNA time. Other data, you can see our occupancy in greenhouse versus traditional, staff turnover in greenhouse versus the traditional, and operating costs. If you think it costs more per day, take a look at the data that we have assimilated here. So where are greenhouse homes? We're 362 homes in 32 states right now. So we've really been able to see it kind of go across the country. And again, this is a kind of a repeat of the process that I talked about with the Best Life approach. When we work with organizations, we're very intentional about what that transformation process looks like. And last but not least is how evidence informs the future designs. What have we learned through the pandemic that would inform the future of our design? So for more information, there's my contact information. You will have access to my slides. And I'll turn it back over to David to introduce Cheryl.
Thank you very much, Susan. And Cheryl, you can start the slides and give your presentation. We're here listening attentively.
Very good. Well, thank you, David, and thank you, Susan, and thank you all for being here. I'm Cheryl Zimmerman. I'm a distinguished professor at the University of North Carolina, I've got a background in health services research and social work and public health. And Susan took you on a very fast ride through the greenhouse model and greenhouse homes. I'm going to focus, as you can see here, on the evidence behind the greenhouse model and small nursing homes, because many of the points that Susan talked about and that I will talk about are relevant to small homes, not necessarily just those that embrace the greenhouse model itself. But certainly this is meant to be very, very much kind of skimming the surface because we don't have time to go into it in great detail. But I think you're going to get a good feel for what's important within the model and within the whole concept of small homes. The 5 areas of evidence I'm going to talk about is what is the evidence about different elements of greenhouse and small homes. I'm going to talk about staffing. How do the greenhouse staffing ratios compare to traditional nursing homes? We all know staffing is critically important. This is something that Canada has recognized the importance of. I know recently the Royal Society of Canada, in their report, they highlighted the importance of workforce reform. The Alberta review talked about how important staffing ratios are, so I'll touch on that briefly. I'll talk also briefly about whether all greenhouse homes are the same. I think about this kind of how green is green. So what really is the fidelity to the model? And then I'll talk about outcomes. What do we know about the outcomes of people who are living in greenhouse homes? And again, that's something that has been well recognized within Canada. The RSC report talked about the importance of reducing unnecessary transfers. I'll have some data that I can present about that. And of course, have talked something about how greenhouse homes fared during COVID and why that is. The data I'm going to be presenting is from comprehensive literature reviews, numerous comparative studies that I've synthesized here, conducted by leading academic researchers, based on primary and secondary data, meaning data that were collected expressly to answer research questions, and then also already existing data, often national data. Quantitative and qualitative methods. I'll tell you a few quotes, some stories about what we heard. Everything I'm presenting has been peer-reviewed and published. There's a lot of data I'm not even going to begin to talk on. So again, both Susan and myself giving you very much of a 30,000-foot view. But if you do want any of the references for what I'm presenting, I'll be happy to provide that to you. So let's just jump right in and talk about the evidence related to elements of the greenhouse homes. This is a webinar, so we're not going to be able to have a conversation. But before I actually show you what the evidence is, I invite you just to think for yourself, based on what Susan told you, is what do you suppose, does the evidence support that it's good to have private rooms and bathrooms? And do you think the evidence supports whether non-institutional and residential style types of dining is good? And having universal staff who work in self-managed teams? And what about having a stable, long stay elder case mix, as opposed to a lot of short stay residents coming in and out? Susan didn't have a chance to talk about that. That's another component of the model. She did comment on the importance of person-centered care, and then engagement. The greenhouse model really promotes people to be engaged, socially engaged, and to think about doing it in a normalized way, not playing bingo, but doing things more like washing dishes and folding laundry. So for yourself, think about, what do you suppose the evidence says? Are these components of greenhouse and other small homes, does it kind of bear them out, or does it not? And the answer is, for all except one of these, it does, but with caveats. I'm going to tell you a few of those caveats right now. When it comes to private rooms with bathrooms, you can well guess, actually very relevant in the concept of COVID, in the time of COVID, reduced infection. So that's a very good thing. Also, people prefer private rooms, so the evidence supports those. That said, we need to be careful because there's more of a risk for social isolation. In terms of dining, non-institutional residential style dining, where largely the greenhouse homes have one big table where everyone, including families, can get together and eat, the evidence shows people eat more. The challenge with that, however, is that there's been some evidence that says sometimes you really need to have more than one space because it can get to be a bit noisy. Staffing, having universal role in self-managed teams, largely the data, the evidence support this, but not everyone is cut out to be an administrator. And it takes extra time for people who are help managing their own teams. I'll touch about I'll say more about that shortly. So again, it's supported, but there's caveats around it. In terms of having a stable case mix, not a lot of people coming in and out, not a lot of turnover amongst the residents, or they're called elders in greenhouse model. Evidence supports that. Largely, there's really not very many negatives around that, other than the fact we want to make sure that greenhouse and small homes have access for everyone. Elder-centered care, choice and control, of course, is important, but it's helpful to think about the fact that even offering choice and control needs to be person-centered. Not everyone will want choice around everything. Also, it's really not feasible to give everyone choice around everything. So it needs to be person-centered. And actually, data have found that more important than choice and control is predictability. If I know what's going to happen, that might matter more to me, and the evidence says it does, as opposed to if I'm the one who gets to decide whether it's happening. And then lastly, there's actually was not good data about normalized engagement. What we've learned is that people actually need to be encouraged to engage in activities. Engaging in activities is important, and I know from conversations with Susan and Susan's own work, in the greenhouse model, this has been something that has been modified so that there is more support to more purposefully involve the elders in different social engagement activities. So moving to the second topic about staffing, again, I'll let you consider whether you think staffing ratios of CNAs are lower in greenhouse homes compared to other homes, ratios of licensed nurses are lower, and whether overall staffing ratios of nursing and non-nursing staff are lower. And the data actually show that for both CNAs and licensed nurses, there's actually, the ratios are higher in greenhouse homes than they are in traditional nursing homes. That's really critically important because we know those CNAs who were called shabazim in greenhouse homes, those are the people who've got the most time doing direct care. So the fact that they're there significantly more is pretty critically important for day-to-day care. Now, at the same time, it's also helpful to see that last line there, nursing and non-nursing staff. Overall, even though there's more CNA time, slightly more licensed nursing time, overall, there is not more nursing and non-nursing staff time. And so there shows there's a certain efficiency because these CNAs, again called shabazim, they're doing, as a universal worker, they're doing a lot of work that could have been done less efficiently by dietary, by laundry, by some of the staff who are helping to do custodial type of work. That said, I also do want to make the point that even though the CNAs are doing non-nursing staff work, they are still doing more direct care time than they are in traditional homes. So moving to the third topic, which looks at components of the greenhouse home. Here's three different components Susan touched on: real home, empowered staff, and meaningful life. These data compare greenhouse homes to their legacy home. Often greenhouse homes have the new greenhouse model, but also a standing traditional nursing home from which the greenhouse homes kind of emanated. And you see a few things on this slide. One, that in these 12 organizations that had greenhouse and legacy homes, in virtually every one of these examples, greenhouse homes did embrace these elements of greenhouse homes much more than did legacy homes. But that said, only one of the elements, which was empowered staff, was done by all 12 of the homes. The open accessible kitchen, 75% of the greenhouse homes did it, and meaningful life, allowing elders to bathe when they want, only 33% did. My next few slides, I've got some quotes that kind of bring this to life and help explain why that is, why greenhouse homes aren't totally green, if you will. So one of the challenges with an open accessible kitchen, with the model saying that, for example, families should use kitchen, one of the Shabazim said, if it's for their elder, for their family member, and other things aren't being prepared at the same time, that's fine. If it's for other elders, or if they're in the kitchen while the Shabazim are cooking for everyone, we have to plan it out. Or we need to make sure it's safe for everyone, like with how things are cooked and textures. We have to follow our guidelines. When it comes to the empowered staff challenge, this whole idea about universal workers, what we heard was our satisfaction with the food was not great because you have 19 and 20-year-old CNAs cooking. Not everyone can cook. Clearly that needed to be addressed. The concept of self-managed work teams, and I referenced this earlier, one of the respondents had said, I think it's a scary thing for some people. They think, oh my gosh, I have to fill these staffing holes and I have to call all these people. It's more time consuming than other roles. So some people aren't natural leaders. That needs to be addressed and considered when one's using a self-managed work team role. And the last example I have here relates to meaningful life. Here's what one administrator said. One Shabazine came to me the other day. She's been in greenhouse for 3 years. She said, it's like it is in the traditional nursing home. When a resident leaves, whoever comes in their spot gets the bath, right? I said, no way, he doesn't have to take the dead man's bath. That's not the way it works. I said, when does he want his bath? And she said, well, I don't know. I haven't asked him. And so what we've seen and what the evidence say is there needs to be ongoing training and ongoing attention to the greenhouse model. So now let's move on to the fourth topic about outcomes. I think it goes without saying, you saw Susan's pictures. If you listened, if you saw videos, quality of life is largely better in greenhouse homes. People would much rather live in a greenhouse home than live in a traditional nursing home, not necessarily in all of the domains, however, but still, largely quality of life is better. That said, there have been concerns about whether traditional quality indicators like this and healthcare utilization perhaps are being minimized. There could be a detriment in more of these medical outcomes because there's more focus on psychosocial well-being. And so given that concern, there has been study around this as well. So I've got some data to show you about this, where these were different measures that were obtained. And what we saw in studies that compared greenhouse homes to other nursing homes, and they controlled for important resident differences to make sure they were comparing apples to apples, they found that residents in greenhouse homes had lower presence of bed fast, catheter, and low-risk pressure ulcer indicators. They also found that in greenhouse homes, there were fewer hospital readmissions and decreased Medicare spending. In the U.S., decreased Medicare spending of over $7,700, a 30% reduction per resident year in greenhouse homes compared to other homes. So why might that be? Well, hospitalization is a big ticket item, so we probably think that's why there was less spending. And in other projects that have been done, we know that better care management relates to lower hospital spending and fewer readmissions, projects like Interact and Evercare, which are new nursing models. So there's good reason to suspect that the results we see in greenhouse homes could be similarly due to these same kind of processes, by which there's close contact with the Shabazim, who are focusing on person-centered care in an environment, a small environment that improves detection, communication, care, and outcomes. So it's the processes of care and the setting in which care is provided that likely relates to not just psychosocial benefits, but these health benefits. So I have two quotes with slides to support why we have this reasoning. One is a physician who said, I walk into a traditional nursing home, and I'm talking to the LPN, who's gotten the report from the CNAs, who's gotten the report from the nurse, who's gotten the report from the nurse that was on before her. You only have to find the Shabazz to get all the information you need about how a resident is doing. And in terms of the environment, the conducive environment, we talk about bumping into each other. When you've got a 10 to 12 bed nursing home, you bump into each other. So a nurse practitioner had said, I ran into an OT who said the elder wasn't doing so well, not progressing, having a lot of pain, so I made a suggestion. The OT said they'd already tried that and it didn't work. So together we agreed on a new approach. If that hadn't happened, meaning if they hadn't bumped into each other, it could have been days to get there, to get to that new approach. So finally, my last two slides I'm going to present about evidence relates to COVID, of course. And I want to orient you to this slide. First, so you see some bar graphs. That purple color, those are the data about the greenhouse and small nursing homes. The flesh tone are traditional nursing homes with less than 50 beds. and the green is traditional nursing homes with 50 or more beds. The second thing you see in the two sets of bars, the first set of bars are COVID cases. These are all US data and compiled US data across the country and across greenhouse homes. So those, the first bars are COVID cases. The second set of bars are COVID-19 deaths from COVID. And so what you're looking at, now I'm looking at the top bullets to tell you what you're looking at, those lines inside the box, that's the median. That's the average number of either cases or deaths. The whole box gives you the large part of the range between the 25th and 75th percentile. The line above the box is where you saw most of the cases, and the dots are outliers. Now that said, the most important thing to take away here is what I've written in blue, and you can see it by the size of these bars. And these were statistically significant differences. The greenhouse model in small homes differed significantly from traditional nursing homes with both less than 50 beds and greater than equal to 50 beds in both cases and deaths. Now I've underlined the both less than 50 beds and more than 50 beds and the cases and the deaths, because all of those tell you a special story, something important about greenhouse homes in this model. And as my last slide, that's what I'm going to highlight. The point is, what we saw in COVID is non-traditional nursing homes are beneficial beyond their small size. There were fewer cases and fewer deaths even compared to other nursing homes that had less than 50 beds. We expect that the cases could have been fewer because, as Susan said, they were made for this time. There's more private bedrooms and bathrooms, fewer staff, and we know that's one of the benefits of and one of the protections against COVID, and also fewer admissions, long stay residents, fewer people coming in and out. But now, why would mortality be less? Why would there be less mortality amongst people once they had COVID? And this may well be where those psychosocial factors are important. We know how important social engagement is, and things such as depression and just the ability to embrace people and feel a sense of meaning that may well have been operative in greenhouse homes during COVID, so that not only were cases fewer, but also mortality. But I do need to point out, even with these significant differences, there are differences between greenhouse and small homes and other types of homes, even just in the context that some settings, some organizations choose to adopt greenhouse homes. And so they might be different, but also residents in nursing homes have fewer risk factors than people in greenhouse homes. And again, nursing homes, and compared to these non-traditional homes, the greenhouse homes, the greenhouse homes tend more often to be not-for-profit and to pay higher wages. So we do have a different workforce there. So with that, I will thank you for your attention. Thank you very much for inviting myself and Susan to present to you today. And just to tell you the great respect we have for all of the different efforts that you are working on in Canada to improve long-term care. And we're looking forward to learning from you now for the rest of today's webinar.
Thank you very much, Cheryl. And thank you very much, Susan, for your earlier presentation. In a relatively short period of time, you've conveyed a lot of useful information and thoughtful information that we'll have to consider. So I want to remind the audience to use the Q&A option to enter any questions. I see some questions have already flowed through, and we'll do our best to address as many as we can during the Q&A session. Now I want to present our panel, and I'm going to briefly introduce our panels all together, and then I'll turn it over to Carol. Our first panel perspective will be shared by Dr. Carol Easterbrooks, who's a professor at the University of Alberta and holds a Canada Research Chair in Knowledge Translation and the Care of Older Adults in Residential Long-Term Care Settings. She has been Scientific Director of the Pan-Canadian Longitudinal Research Program called Translating Research in Elder Care, or TREC, since 2007. Carol has also led the development of the Restoring Trust Report on the state of long-term care commissioned by the Royal Society of Canada following the devastating first wave of COVID-19 pandemic in our country. And I would mention that there is a link on on the event page to that report. Next, we'll hear from Dr. Lorian Hardcastle, an associate professor in the Faculty of Law at the University of Calgary. Lorian's research interests include the regulation and governance of the healthcare system, liability and accountability of health facilities and government, patient safety and the law, and the self-regulation of health professionals. Our third and final panelist will be offered by Mike Conroy, the president and CEO of the Brenda Strafford Foundation. The foundation operates 5 local continuing care facilities, and Mike has been instrumental in establishing the foundation's distinctive focus on research and innovation within the continuing care setting. As president and CEO, Mike is responsible to the foundation's board for strategy and strategic development and implementation, as well as the effective and efficient management of all aspects of the foundation's operations. Carol, please share your presentation and start your talk.
Great, thank you very much, David. See if I can make that happen. Excellent. So I want to thank the Brenda Strafford group for inviting myself and others, and really I want to give a special thanks to the previous 2 speakers. It's really been delightful. I'm going to talk a little bit from the perspective of root and branch overhaul, which really fits this topic really well. And if the previous speakers gave a 30,000-foot view, mine will be like 90,000 feet in a briefer time. So bear with me. I come from 2 perspectives. One is the perspective of the program I lead, which works inside very traditional long-term care or nursing homes in Canada in several provinces, and really focuses on various quality dimensions: quality of care, life, end of life, and quality of work life for care providers, using both improvement science and implementation science and various and sundry other perspectives. We want to contribute to transformative system change, but I want to emphasize the word contribute, because transformative system change is a big ticket, complex thing to do. We're all about, especially the last 7 to 8 years, moving ideas to implementation or system scaling. So hearing about what's happening with the greenhouses across the US is very exciting. And one of the things I thought I would do is just introduce a couple of other, just skim over the tops of a couple of other models that I'm familiar with that have very, very similar principles and core values, but some differences that I think might help us understand there's a tremendous variety of small facility living. The restoring trust process, doing this report with the panel, was sobering, sometimes discouraging, sometimes heartbreaking, because we were doing this, as you recall, right on the tail end of wave 1, where Canada had the tremendous shame of having the worst record in the world of percentage of Canadian deaths happening in long-term care. And there are, I won't go over these, many, many long-standing, deep-seated issues that have to do with why we ended up in the conundrum and the terrible situation that we did, not the least of which is the highly medicalized model within which the majority of our nursing homes or long-term care homes work. We had a lot of trouble with boiling the ocean in the Restoring Trust report. We didn't have a lot of time to do it, and there was a lot that could have been recommended. So we made a series of recommendations, but we came very quickly in one particular meeting that I recall well to the fact that there had been a perfect storm brewing for a long time in Canada and elsewhere in the world, with increasing resident complexity, shorter lengths of stay, more advanced stages of dementia, more frailty, more multiple comorbidities, et cetera. That had been progressing and marching upward for at least 2 decades. But the workforce capacity had at best stayed flat. It hadn't really matched that increase. And in fact, there were a whole lot of other issues happening within the structure of the workforce, which, as you all know, is in Canada about, give or take, 90% of direct care is given by personal support workers, care aides, nursing assistants, that group of unregulated, or at least at this point in time, unregulated workers. So those 2 things were coming together and had been for some time in structures that were older, with all the other things that were happening in long-term care. And then we had a global pandemic, and we bore the consequences of that in very deep and painful ways. This is the motley crew that made up the report, a couple of Albertans on it, but we tried to get representation from across the country because, of course, in Canada, we spend a lot of time making sure we have balance of gender and balance of provinces and balances of language and all sorts of other things. So it was a pretty good group, and they worked really hard in a short period of time. And there's a backstory, which I will never have time to explain about the cover, but we're pretty happy with it. But it was a long time getting to a place that we thought represented the main resident of long-term care, which is older women who do not have significant financial resources. So our main recommendation and what we said in the report was, if you do nothing else, if the only thing that was ever done, and of course there's much more that needs to be addressed, the workforce issues, we thought the greatest gain would be had by focusing there first with significant effort. There are many, many other things. We were acutely aware of the extreme isolation that many residents and families had experienced, as well as all this other things. And in Canada, we have a particular flavor of federal, provincial, and territorial relationships that has made it sometimes very difficult to negotiate change. And then the other big recommendation was to undertake a root and branch overhaul of the long-term care system, which is going to require thinking like that we've heard from Susan and Cheryl, not just tinkering around the edges of how do we reduce falls and reduce pressure ulcers and all those other important, but nonetheless very medicalized things, so that we can move to a different sort of experience for older adults. So I've been coached for 2 decades now by Dot Pringle in Toronto to stop thinking about quality of life in a traditional way and to start thinking about quality moments. And I heard Susan reference these. We have nursing homes that are populated largely by people with cognitive impairment, a significant proportion of which have dementia, the majority. And they have a temporal disruption that really interrupts how we traditionally think of quality of life. And so this should be, many of us believe, about moments. And I don't know how many moments it takes to make a good life at the end of life, but it takes more than what most countries running very traditional long-term care models are able to provide. And it requires, I think, a social care system that is at least as dominant and perhaps the more prominent model that we work with, as opposed to the highly medicalized approach that we have right now. So I'm going to just briefly show 3 models that are similar in many ways, but different in others. You all know about the dementia villages in the Netherlands. They're contained villages where people are able to live more normalized lives and engage in activities that are more normal to them, and create, one hopes, and we see some evidence of this, moments of enjoyment and pleasure and quality. Many of you on the call have visited some of these homes. We don't have any exactly like this in Canada, but we do have some people experimenting with dementia village concepts. Where I want to go, my own personal preference is take me here to Tucson, because it's private for profit and it's very expensive, but it's running a really innovative equine facilitated care approach. Barbara Rector is the great grandmother of all things equine in that part of Arizona. And this is a culmination of a lifetime of work with the power of equine facilitated support. I witnessed her working with a number of women with dementia, and it was nothing short of magical. So it is a model. It won't work everywhere, but it works in this environment. And if they had the means and will, they could make it work in more facilities in this and similar environments. It has a lot of other components to it too, but it's the equine piece that I have been so taken with. And then maybe overall, if I were to say, here, what models do you like? Here's one that I'm very fond of, because it's very dominant in Norway and the Netherlands. Not dominant, but prominent is a better word. In France and some other regions, there's a big effort around care farms, not just for older adults and people with dementia, but for people who've been incarcerated, for troubled youth, and many, many other populations. But these are small I think it's fair to characterize them as working hobby farms. They produce produce, they produce eggs and milk. They have all sorts of normal farm animals. And the residents engage in the care and tending to their abilities of the animals, of the produce. They help cook, they use sharp knives under supervision. And they do things that those who have this kind of background are used to and have some meaning to them. They also have nice outcomes, at least the reports I've been reading have good outcomes around physical activity, increased social interactions and engagement. And I've been very influenced by a student I had spend a summer there and do some research with a group in Amsterdam, and very impressed by the way she described to me the way people who die in these homes. It's not the long lingering death that we often experience in some of the facilities we have in North America and certainly in Canada. So that's another favorite model, but it has very, very many similar attributes and value systems and principles to what Susan described in the greenhouse model. Just a bit different. Japan's experimenting because they don't have the same landmass with small urban green farm, more like green gardening models that fit into smaller footprints and don't have to accommodate farm animals. So there are different countries or in different jurisdictions are experimenting with variations on all of these small models. That's the end of my presentation. I've really skipped across the top, and I've been very influenced by this statement by Albert Einstein. We have been doing the same thing over and over again for decades and decades and decades. And if we continue to do it, we'll of course get the same outcomes and have the same mess in the next pandemic or disaster that we have now. So hopefully we're in a position where there are windows of opportunity and policy and change afoot that will allow us to step forward. So thank you very much for your patience and for listening to me. It's been a pleasure.
Thank you, Carol. So our next speaker will be Florian. If you could get your PowerPoint up and start your presentation, that would be wonderful. Thank you.
Sure. There we go. Okay. So I'm going to actually pick up on a number of things the other speakers have outlined, but specifically from the perspective of thinking about the law and regulation and some of the challenges that poses. Okay. I see a note in the chat that we're running behind, so I'll be concise. So the first thing that I think people tend to do when they think about new models of care or new ways of doing things is pointing out some of the legal barriers to that. And so, for example, we might hear people talking about things like, well, what about labor law? And can you have, in a unionized environment, can you have people doing both healthcare tasks and then these other daily living tasks? And does that structure work within particularly facilities that are unionized? Oh, sorry, my video was on. Thank you. Anyway, can you even accomplish these sorts of models in an environment, for example, one that's unionized? Another issue that people might bring up is an insurance issue, and certainly there are challenges with long-term care facilities obtaining insurance. That's something we hear lots from them here. And so what would insurers say about this other kind of model where potentially people are engaging in activities that an insurer might see as more risky from a risk management perspective? Others might draw attention to things like accommodation standards or building codes or fire codes, and can we set things up like this? And this is something that Greenhouse saw in the US. For example, the Centers for Medicare and Medicaid, there were regulatory changes to allow things like gas fireplaces in common areas and chairs in groups of seating in corridors and open kitchens. So there had to be regulatory changes to allow this. What I don't think we should do, though, and I think we do all too often, is saying, there's too many legal barriers. These are legal barriers. We can't do this, because I don't actually think that there are true barriers to implementing these kinds of models. I do think that there are potentially legal challenges that require us to think through them and require regulators to be thoughtful. But I don't think that they're true barriers, or that there are things that bar us from embracing these kinds of models. And indeed, we already do have regulatory flexibilities. For example, it's not a directly relevant example, but for example, under the Public Health Act, there are obviously very detailed food handling regulations for facilities. But we already, for example, exempt group homes with less than 10 people from those regulations, recognizing that what's appropriate for a large facility may not be necessary for a smaller one. And that certainly isn't the only example. We also only apply certain continuing care regulations to facilities with a certain number of residents. So there is that flexibility and that regulatory creativity. There already is the possibility for that. And so, one note of caution is just to not say, well, there are these legal issues and so we can't do this, because I don't think that, again, that they're true barriers. Another potential legal issue that sometimes comes up is, well, what about the economies of scale that larger facilities are able to achieve in complying with regulatory standards? And Alberta is not, I suppose, what you might think of as a super regulated jurisdiction in terms of long-term care compared to some of the very, very detailed legislative requirements in a province like Ontario. And I think that these kinds of facilities would potentially have more trouble in those kinds of provinces where there is a lot of reporting, a lot of regulatory compliance. BC is another jurisdiction with a lot of reporting requirements. But again, I don't necessarily see that as a true barrier. Again, we can have more flexible regulations for facilities under a certain size, or facilities with particular patient populations. The facilities themselves, though, may also have to think about what kinds of organizational structures they can have so that they can take advantage of those economies of scale that larger facilities may be able to achieve. For example, if there are several, let's say a facility like this, several small facilities in a given province, is there a way that they can have a common organizational or administrative office that can deal with some of these regulatory issues for the entire suite of facilities? Another potential issue that I think might come up in the context of smaller facilities is, well, what does that look like from a government enforcement perspective? Governments already struggle with doing enforcement in terms of the facilities that we do have, and already struggle with getting through the requisite inspections, responding to reports. And so the government may be resistant to smaller facilities, potentially for that reason. Again, I think that this isn't an answer to, this isn't a barrier. The response isn't, well, we'll have difficulty with enforcement, so this can't be done. I think that where we would need to go, though, is either ramping up enforcement staff, which is something that many people call for in any event, or being more thoughtful in terms of what enforcement looks like. Is it Alberta Health and Alberta Health Services doing duplicate inspections, which can happen now, or is it that they come up with a way of being more efficient? We have facility level data on various patient or resident outcomes, and so maybe our regular inspections or our enforcement is targeted more to where we're identifying problems. So what one might call evidence-based regulation. Another potential issue that may come up in this space is philosophical differences, and I think we heard this from some of the other speakers. Philosophical differences between what these kinds of smaller facilities like Greenhouse are trying to do and then the philosophy that I think underlies regulation. And I think how I've labeled this is that the philosophy behind these facilities is really a quality of life philosophy, whereas I think that regulations tend towards a quality of care philosophy. And we heard this from Carol when she talked about the medicalization issue. And I think that the regulations are equally medicalized. I think if you look in the standards or in the regulations, they do tend to focus more on those physical care, physical condition kinds of issues, more so than they do on some of the quality of life, the food, the recreational programming, those sorts of issues. And this is even more pronounced in provinces that have tended towards more detailed regulatory standards like Ontario, where there are really detailed regulations about a variety of quality of care issues. And I think, of course, that focus on that sometimes comes at the expense of quality of life. I do, though, think that on the sort of more optimistic side, the red is like the pessimist, the orange is the optimist. I think on the more optimistic side of things, though, I think we are seeing a shift in regulations towards more focus around quality of care. And so to the extent that we can continue in that direction, I think we'll see regulations embrace this kind of philosophy more. And certainly I've read that that's been the case in the US, but is also the case here. For example, various provinces mandating in their laws resident and family councils, requirements around recreational programming, requirements around food. So more quality of life rather than just quality of medical care or health care provided. And so I think, though, and again, Carol mentioned this, I think we have a real window of opportunity here to potentially consider implementing this kind of model in Alberta. And so I think we're at a good point to be considering this issue. And of course, we've heard from some of the other speakers that COVID-19 has really shone a light on some of the issues that we see in continuing care, and these kinds of smaller facilities for a variety of reasons, be it the private rooms, be it fewer contractors coming in and out to do laundry and to do food and to do all of those things, a variety of reasons why why these facilities perform well during COVID. But COVID has created a window of opportunity for us to do creative things in this space. And policymakers are indeed considering legislative changes at this time. And I think that those of you who work in this area need to get in the ear of policymakers, because I think that when something bad has happened in long-term care, often the response is, we need more regulations, we need more detailed regulations, we need to regulate more stuff. And I'm not sure that that's necessarily the right response is more. I think it's more thoughtful is the right response. I think that certainly this is a government that's very polarizing in terms of their health policy making, but I do think that there's certain aspects of this kind of model that would appeal to them. And so, for example, we've heard from this government that they are one that supports innovation in healthcare delivery. We've heard from this government that they support choice and that they want to reduce red tape. And so I think that in some ways, this fits within their branding. And so there may be a policy window with this particular government to do this. And again, an unrelated example, but we've seen this in the context of the regulation of early childcare facilities. And what we saw there was them wanting to shift the regulations to enable more choice, different models, and certainly those regulatory changes are again polarizing. But I think that it fits within their branding and the kinds of legislative choices that they've made to potentially shift towards this kind of model. I think another reason that we have this window of opportunity right now in Alberta is because they have actually committed to changing continuing care regulations. And so I think that one way to be more flexible in terms of the legislation is to potentially consolidate the continuing supportive living regulations, the nursing home regulations, and to look at it as sort of a holistic package. And here is how we want to regulate seniors care. And these are facilities that should be exempt from certain rules because they're small enough. These are facilities that should have these rules. And this again is something that this government has done in other contexts. They recently consolidated the hospital regulations with the chartered health facilities regulations into one Health Facilities Act. And so this is similar to that. And so the final note that I'll make is that this is also a government that has expressed a desire to be fiscally restrained in its policies. And so to the extent that one can make the business case for this kind of model, I think there may be a window of opportunity there as well. So I'll wrap it up there, and I'll turn it over to the next person.
Okay, good evening, everybody. I appreciate what time it is, so I'll go through my presentation fairly quickly. So Chantal, do you want to go to the next slide? I'm going to give a bit of a operator or provider's perspective about the small facilities in Alberta. For those of you that have been around for a while, you may know that in the late 90s, there was quite a large emphasis on small facilities and exploring the benefits of small facilities in Alberta. And this wasn't an Alberta grown initiative. It was based on a survey of good and best practices out of the US with Woodside Place, the Helen Bader Center, the Adard model in Tasmania, in Australia, the Center for Health Design, et cetera. And it was all around some of the characteristics that we've heard: a change in philosophy in the care model, that was moving from the medical model to a more home-like model. Their design attributes were very similar to what Susan mentioned earlier in terms of small group living, 10 to 12 people per house or cottage, if you will, 3-piece bath, all private rooms, shared kitchen facilities, fireplaces, contained garden areas that were available, single family or single story dwellings, etc. And so, and a lot of these were focused on residents with dementia needs, again, based on the research and trying to increase positive stimulation and reduce negative stimulation. You see some of the names on the screen. So there's a lot of energy around this. And, you know, here we are 20 to 25 years later, and we haven't seen this model being adopted very widely at all, as David said at the outset. And there are reasons for that. And, you know, most of these sites that were quite visionary at the time and espoused as visionary by the Ministry of Health, et cetera, have now been reconfigured to conform, but not only, it's really unfair to say AHS, but their predecessor organizations to configure to a service and funding model that more closely replicated the institutional funding model, because that was the prevalent model. And that subordinated the benefits both from the environmental design and the programmatic benefits. So there are reasons for that. What are the barriers? Next, Chantal. So I'm not going to go into the detail with these, but the service model became challenging. And we talked about having residents participate in normalized activities, whether that's meal preparation, laundry, gardening, those types of things. And in some cases that ran up against public health regulations around food handling and infection prevention and control, just risk tolerance overall and acceptance of risk, especially for staff moving from an institutional model, but also trying to develop a stronger partnership in care with both residents and families and with funders. And the cost, quite frankly, I think we'd all be envious to what Cheryl said was 5.6 hours per resident day, when in Alberta we're still dealing with about 3.2 at the highest levels of care. Staffing model is a real challenge, especially within the framework of the funding and accountabilities that are required. And I worked in both BC and Alberta, and I can say that the staffing accountabilities in Alberta are far more prescriptive than BC. The role of the support for the multi-skilled workers, there's still a sense by regulators and funders that multi-skilled workers actually subordinate the quality of care that's provided, and access to allied health staff only because of scale, and that's also reflected in the research. Funding models in terms of not only limiting resources, but more specifically, how those resources can be deployed. We are the only province that has a cap on or doesn't use income testing for establishing accommodation fees, and that has a certain implication for capital funding. And our funding model is acknowledged as not designed for small group living. And when you're building, especially with the building codes for residential care facilities, there is a higher per unit cost in small group living arrangements, especially single story. And also in terms of capital deployment, the province has really been focusing on system capacity. So all of the new sites that have been built over the last 20 years are large sites because again, the province wanted to optimize capacity. And there's also an issue, and again, even reflected in the greenhouse literature around what happens when with higher acuity or adults, when their needs change over time and they become significantly dependent on care and care support in the small group living environment. So there is some reason for optimism. Go ahead, Chantal. In terms of, we've heard a little bit about the facility-based continuing care review, and I'm not here to promote this, the review, but there are some recommendations of the 42 in the various policy areas that specifically, I think, support and enable finally the ability to realize the full potential and benefits of small facilities like the greenhouse model. So one of the recommendations was, from the report, was to establish quality of life versus quality of care as the #1 priority for reform within the facility-based continuing care sector, and they do cite the greenhouse model. There's also a commitment to refocus the capital grant program to, again, prioritize a greater variety of client-centered models, including small homes, and David spoke to the objective of having 1,600 by a certain date. Improving the provision of culturally appropriate continuing care services, again, small group living, given that the scale can be quite accommodating for different cultures and ethnicities. One thing that's very encouraging, and I think again an enabler to get to the care hours that we heard earlier, is a commitment to increase care hours by a significant amount over the next 4 years, or by about 40% in long-term care and 60% in designated supported living. Go ahead, Chantal. And some of the other recommendations, supporting consistent staffing assignments, which is actually facilitated by smaller facilities. The introduction of self-directed care options, where actually the funding could be managed by the family or resident, and so give rise to cooperative type of models that could support small group living. Again, a commitment around research, technology, and innovation in continuing care. So it seemed to be an appetite or a renewed appetite for innovation in this space, which and hopefully evaluation, and us actually as a province contributing to the body of knowledge around small facilities, and evaluating the patient care based funding model and its impact, especially as it relates to the ability to support the types of service models that are required in small facilities, and also looking at the operation of smaller homes to facilitate their implementation around the funding model, which right now makes it very challenging for any facility lower than, in fact, 75 beds. So hope and skepticism springs eternal. So even though this report, the Alberta Facility-Based Continuing Care Review, was released in June of this year, 2021, and included some of the impact of COVID-19 on facility-based care, these recommendations have yet to be formally accepted by government, so we're waiting. And again, we always have to be mindful that we in Alberta are part of an integrated health system, and sometimes, as I call it, the tyranny of the acute care capacity starts to drive policy and practice. And that's really been the case over the last number of years, where because of hospital pressures, one could argue that they're somewhat, from a health system point of view, self-inflicted, but there's a great emphasis on quantity versus quality, i.e. building capacity in the facility-based care area to facilitate hospital discharge versus to support people and optimizing their quality of life. And there's also a potential to move forward with small facility projects without government support, but there are some scale and sustainability concerns, and there could be models such as co-op in terms of ownership and tenancy, such as life lease, et cetera. But to really scale this type of model for the benefit of Albertans, both rural and urban, I think it will require some government support and intervention. And that's it. Thank you very much.
Great. Thank you very much, Mike. I'm really thankful for the speakers and panelists for answering as many of the questions that have been submitted as they can over the course of the presentations, because obviously we are running late and we're going to have to move on quickly. But there, I guess one question I would ask of the panelists, and Carol and Lori and Mike, is I'm interested very much in the universal worker and universal provider. And I just wonder, one, how well prepared is current workforce in long-term care for that type of role? And how feasible is it to move towards that model? I know Lorian said that she's not overly concerned, and I don't want to put words in your mouth, Lorian, but about the regulatory barriers or potential barriers. But I'd just be curious to hear what you think about this different type of universal worker.
I can jump in. I think it's possible, but obviously there's a landscape to navigate around collective agreements and unions and all those sorts of things. We know that the current worker in Canada is probably underprepared for the complexity of the resident, but that doesn't mean that we couldn't look at how a universal model would work. And I think it could. It's going to take some effort and planning. And it's probably, as I think I heard Susan and Cheryl say, or imply, about the balance, because that isn't the only person in these facilities. And so what's the right mix and balance required to support that kind of an approach? And are we remunerating them properly? I mean, I think that's a little bit of an elephant in our room here, is regardless of what their role is, are they properly remunerated for this really important complex care?
Thank you, Carol.
One thing I might add to that I think is an interesting development that's of course happening in Alberta is recent legislative changes will actually bring healthcare aides as a regulated health profession in with licensed practical nurses in the same college. And so it does make me sort of ponder, which way will that go? Will recognizing them as a healthcare professional and having them in the same regulatory college as licensed practical nurses potentially more deeply entrench the medicalization and that we heard about, or will it just have perhaps the positive benefits that the government intends around more uniform standards of training and those sorts of things? So that's maybe an interesting legal issue in this space that we'll have to wait and see. And no, you didn't put words in my mouth. I think the point is just that I think we're very quick to say this is all a problem, and I think my view is just that it's a challenge that can be worked through. And of course, some workforces are unionized, some are not. It would really depend too on the nature of the collective agreement. So there would be work to be done, but I'm watching for sure the changing role of healthcare aides following those changes.
And typically they would try to blend the care aid component of the role with the hospitality functions such as housekeeping and the food services, perhaps with a little bit of either recreation or rehabilitation therapy assistant in there. And that gets to be quite broad. So now we're expanding the HCA curriculum, then we're adding all these other functions that requires training and expertise. Then you've got a question, especially given what Lorianne said about people getting focused on their scope of practice, how appealing is the role to people? And so you're going to have to make it appealing. And I think to Carol's point, compensation is part of that equation.
Yeah. Now, we do have one final presentation, and I'm afraid we're going to have to move to it, but I'll come back at the end of my closing comments about what we'll be trying to do with the questions. It's a great pleasure for me to introduce Kim Brundred, to share information about a local initiative being led by the Dementia Network Calgary. Kim is the collective impact lead at Dementia Network Calgary. For the past 5 years, Kim has been engaged with people with lived experience, other stakeholders, and community leaders to raise awareness about dementia and advocate for improved community supports. Over to you, Kim.
Thanks, David. Share my screen here. Yeah, so the Dementia Network Calgary I've just put up on the screen there some of our current priorities, and we're obviously here to talk about the third one, which is around small community-based homes. So we started that work just kind of by doing a survey of what's existing out there now in Calgary and Alberta, Canada, and around the world. And then we met with current operators of small homes to find out what their challenges are in sustainability, and what they would like to see changed in order to keep their homes functioning as well as possible. And then in November, we had the opportunity to meet with people impacted by dementia. So people living with a dementia diagnosis, as well as people, their loved ones and families, and talk to them about what they would like to see in small home models. Now, we did give them a giant magic wand and say that we're going to assume we have a competent, caring, and consistent staff, which obviously we've heard tonight is probably the most important component of the small home model. So we took that away and assumed that was there. And this is kind of a really brief document about outlining what we heard back from those families. So obviously quality of life is number one, and design of the home, family involvement, person-centered activities, meals would be important to both the residents and their families. So in January, we look forward to meeting with policy and decision makers to share what we've heard both from facility operators and from people impacted by dementia, and talk about how we might be able to move some of this forward. So I'm thrilled to hear the information tonight. And then finally, in the spring, we hope to convene some conversations with people or organizations who are interested in moving forward and taking some action. So we're very thankful to be involved in this discussion tonight and have the opportunity to share our work that we're doing in the community. I found that the information tonight really gave us some evidence that we need to be able to advocate effectively going forward. And if you'd like to get involved in our work, or you're interested in attending any of our future sessions, please feel free to email me directly or pop onto the website and you can sign up for our monthly e-newsletter where you'll get all the information. Thank you.
Thank you very much, Kim. I'm just going to make closing statements. We are close to the witching hour. I really enjoyed the session. I enjoyed the presentations. I really want to thank Susan and Cheryl for the information you shared with us. Very insightful, addressed a lot of the questions that I know our audience had. I also want to thank everyone who was able to help in responding to some of the questions that have been submitted during the course of the event. I do want to tell everyone that we'll save the questions and try to follow up appropriately as best we can. We'll try to respond as well to the questions that were entered at registration that weren't addressed. I should mention those questions were shared with our speakers and panelists to give them an idea of what was being raised as issues. And they did their best to tweak their presentations to address them. And I think they did a great job. So I also would like to thank our three panelists, Carol, Orion, and Mike. And also I want to thank Kim and the importance of following through with this work via the Dementia Network Calgary and their activities. I want to thank the audience, encourage them to stay involved in this important dialogue. And I want to thank the O'Brien Institute for Public Health for the technical support and assistance in publicizing the event. The event also made it very clear to me that this is complex, and it's more than just building a small facility. There are a lot of issues we have to think about. And I think the workforce is key, the culture is key, and they have to be thought about together in an integrated fashion if we're going to make true, meaningful reform for our friends, our neighbors, our family members who are in continuing care, and many of us who will be in continuing care in the future. And that's not to negate the importance of trying to allow and support aging at home, but the reality is that a proportion of us will require this level of care, and it has to be done in as humane and as meaningful for us personally manner as possible within the constraints of the cost, the regulatory environment, which is, I don't think, as Lorraine said, a major impediment, but has to be thought about and addressed in order to make this happen. Again, I'd like to thank everyone for attending, and we will follow up as best we can with the questions. And good night and Godspeed to everyone. Take care.